Ever felt like you're just drowning in articles, trying to cut through all the noise and get to the absolute core of a complex topic?
Yeah, information overload is real.
Well, you are definitely in the right place. This deep dive is your shortcut to becoming truly well-informed. We extract all those crucial nuggets of knowledge so you don't have to sift through pages and pages.
Making it digestible.
Exactly. Today, we're plunging into a surprisingly tricky and often challenging area of equine internal medicine. Urinary tract issues in horses. Now, it might sound a bit niche, but our sources reveal it's actually a really complex landscape. We've gone through some incredibly comprehensive guides, detailed perspectives on equine UTIs, related conditions, all to bring you the most important insights.
Synthesizing it all.
Right. So what you can expect today is, well, a journey. We'll go through what these problems actually are, some truly surprising facts, a deep dive into causes, how vets figure out what's going on, and, of course, treatments.
The whole picture.
Basically, we're giving you the fast track to really understand this complex area quickly.
Okay, let's unpack this. Because honestly, for anyone who cares about horses, these hidden complexities are just critically important for their welfare.
It's definitely one of those topics that really highlights how interconnected everything is in a horse's body. What might seem like a straightforward issue can so often point to much deeper underlying problems.
So let's start by getting our terms straight. For our listeners, when we talk about a urinary tract infection, or UTI in horses, what are the key distinctions? Are there different types, maybe affecting different parts?
That's a great place to start.
Yeah.
When vets talk about UTIs, we broadly categorize them into two main areas. You've got issues affecting the upper urinary tract, so that's the kidneys and the tubes leading from them, the ureters.
Okay.
And then there's the lower tract, which is primarily the bladder. Now, most often we are dealing with bacterial infections, but it's important to know that sometimes yeast, certain protozoa, even parasites can be the culprits too. Right. And beyond just an infection, I noticed our sources put a lot of emphasis on another critical term, urinary incontinence. What exactly is that?
Ah, yes. Urinary incontinence, or UI. Basically, it's the involuntary leakage of urine. Think of it like this. The pressure inside the bladder just gets too high, and it overwhelms the urethral sphincters, those little gatekeepers, meant to hold urine in. So clinically, you'd see a horse maybe constantly dribbling urine or perhaps intermittently.
Okay.
This often leads to a pretty distinct urine odor. And in chronic cases, you'll definitely notice significant urine staining and scalding of the skin, usually around their hindquarters or inner thighs. It's really quite uncomfortable for them.
Right. And here's where it gets really interesting, a real aha moment I found in the sources. True bacterial UTIs in horses are almost exclusively ascending infections, meaning bacteria are coming up from the outside.
That's generally the case, yes.
And a major challenge is that if you're seeing incontinence, it frequently signifies a chronic end-stage process. It's not usually something that just popped up yesterday.
Exactly. That's a critical point.
The big takeaway here seems to be that incontinence is rarely the first sign, but often the alarm bell for a problem that's been brewing for a long, long time, maybe even years.
Precisely. And this points to a distinct pathological cascade, a kind of snowball effect, where an issue that started subtly can spiral into chronic damage. It often starts when a horse's bladder doesn't empty completely for whatever reason.
Okay.
Urine pools. This stagnant urine, over time, leads to the progressive deposition of sabulous sediment. Imagine like a thick, gritty sludge, a mix of calcium carbonate crystals and mucus collecting at the bottom, the ventral part of the bladder. This retained urine and sediment then chronically overstretch the bladder muscle, we call it the detrusor muscle, and irritate its lining.
So if I'm picturing this, it's like a balloon that's always a little too full, and slowly that constant strain just wears out the elastic. Is that kind of right?
That's a pretty good analogy, actually. That chronic stretching causes the bladder wall to lose its natural elasticity, its ability to contract effectively. Right. This leads to a progressive loss of the detrusor's function, which culminates in bladder paralysis, also known as an atonic bladder. At this point, the bladder is essentially flaccid, massively distended, leading to severe overflow incontinence.
Wow.
And that stagnant, irritated urine, full of sediment. It becomes a perfect breeding ground for a secondary bacterial cystitis, a bladder infection.
So the infection comes after the mechanical problem starts?
Often, yes. So the key takeaway here is crucial. Sabulous cystitis, that gritty bladder sludge, is typically a consequence of the underlying bladder emptying problem, not the primary cause itself.
Right.
Simply removing that sediment, maybe surgically flushing it out without addressing the root issue of why the bladder isn't emptying properly.
Mm.
Well, it almost certainly means it's going to come back.
Makes sense.
This is why early and accurate diagnosis is just so vital. You need to interrupt this cascade before that irreversible damage occurs to the bladder muscle. Hashtag tag tag 2. The body's defenses and why they fail.
That complex cascade really highlights how delicate the balance is in a horse's urinary system. Let's talk briefly about how a horse normally urinates. It's called equine micturition, right? And it sounds like quite an intricate reflex involving both involuntary and voluntary control.
It is quite sophisticated, yes. And what's really interesting, actually, is that despite, obvious opportunities for bacteria to get in, true UTIs are considered uncommon in horses.
Really? Uncommon?
Relatively speaking, yes. Their overall incidence is quite low. This tells us that healthy horses must have remarkably robust natural defense mechanisms against these infections.
Okay.
So the flip side is, when a UTI does occur, it's very often a secondary problem. It signals that there's probably an underlying predisposing factor that has compromised these defenses. And this completely shifts the diagnostic focus. It's not just about finding the bacteria and picking an antibiotic. It's about diligently searching for and hopefully correcting the primary anatomical, physiological, or maybe neurological dysfunction that allowed that infection to take hold in the first place.
So this raises an important question then. What compromises these normally robust defenses?
Exactly. What lets the bad guys in?
And we should just mention again the impact on the horse's welfare and performance. It can be substantial, right? Especially chronic cases. That distress from constant urine staining, the skin scalding, the odor. It really highlights why finding that root cause is so crucial for the horse's comfort and quality of life.
Absolutely. Imagine trying to live with that constant irritation and smell. It's significant.
Yeah.
Hashtag tag 3. Untangling the causes and risk factors.
All right, so that's a good segue. Given how robust these defenses usually are, when they do fail, what are the main reasons? Our deep dive showed a pretty wide range, broadly categorized into neurological disorders, things that are born with congenital anomalies, acquired conditions, and even factors that are sometimes, ironically, veterinary-induced or iatrogenic.
That covers the main areas, yes. When we look at neurological causes, urinary incontinence often points to a breakdown in those complex nerve signals controlling urination. We generally talk about two main types of nerve damage based on where the lesion is.
Okay.
First, upper motor neuron or UMN lesions. Think of these as damage higher up in the spinal cord, maybe the brainstem or thoracic lumbar spine.
Yeah.
It's like the main control center isn't talking properly to the exit gate, the urethra.
Right.
So the urethra often clamps down too tightly, increased resistance. The bladder might try to squeeze, but it struggles to empty against that resistance. Clinically, you might see horses urinating in short, intermittent bursts. And when a vet feels their bladder rectally, it often feels quite turgid, like firmly distended.
And other signs, too.
Often, yes. Horses with UMN issues frequently have other nerve signs affecting their movement, like ataxia, wobbly gait, or weakness.
Okay. And the other type?
The other type is lower motor neuron, or LMN lesions. These affect the nerves lower down, in the sacral spinal cord, or the peripheral nerves directly connected to the bladder and its sphincters.
So closer to the action.
Exactly.
Right.
Here, the bladder muscle itself becomes weak and floppy, flaccid detrusor paralysis, and the urethral sphincter can't hold properly. There's reduced tone. The result is typically a continuous dribbling of urine from a perpetually full bladder. We often call that overflow incontinence.
How does the bladder feel then?
On examination, the bladder feels large and flaccid, very soft, and it can often be easily expressed manually by a vet. And you might see other element signs too, like a floppy tail, maybe difficulty passing manure or reduced anal tone. It's worth noting, though, that in very late chronic stages, a UMN problem can sometimes start to look like an LMN one as the bladder gets exhausted.
Right. And we saw examples of specific neurological conditions that can cause this. Things like EHV1 myeloencephalopathy.
Yes, equine herpes virus type 1.
EPM, equine protozoal myeloencephalitis.
Common cause, EPM.
Or even physical trauma to the sacral area, that lower back region. Or specific nerve damage like neuritis of the cauda equina.
Inflammation of those nerve roots.
And even certain plant intoxications like from sorghum species or Johnson grass apparently can cause bladder paralysis.
They can, yes. Neurotoxic effects. Now, beyond neurological issues, congenital anomalies problems a horse is born with are important causes, especially of incontinence starting early in life.
Like what?
The most common are probably ectopic ureters. That's where one or both tubes connecting the kidneys to the bladder don't insert in the right place. They might bypass the sphincter mechanism, leading to constant leakage, often from birth, more common in fillies.
Okay.
In foals, you might see a patent urachus. That's a fetal connection between the bladder and the umbilicus that should close after birth but doesn't, causing urine dribbling from the navel.
Got it.
Then we have urolithiasis, which is just the term for urinary stones or calculi. These often cause straining, blood in the urine, signs of pain.
Right.
And remember, cystitis, that gritty sediment. As we discussed, that's usually a consequence of incomplete emptying, often due to one of these other problems, not the primary cause itself.
Okay, it keeps coming back to that.
Really has. Trauma can also play a role, maybe breeding injuries or difficult foaling, dystocia. And then there's a curious one we sometimes see, mainly in geldings, called idiopathic bladder paralysis syndrome.
Idiopathic meaning we don't really know the cause.
Exactly. These horses show incontinence and that sabulous urolithiasis, but without obvious overt neurological deficits on exam. Vets suspect maybe subtle nerve issues that aren't easily detected, or perhaps chronic pain in their lower back, the lumbosacral area, might be preventing them from posturing and urinating normally.
That's fascinating about the chronic pain link. We should definitely circle back to that. But before we do, you mentioned estrogen-responsive incontinence in mares earlier. How does that work?
Right. In some older, usually spayed mares, a drop in estrogen levels can apparently lead to lower urethral sphincter tone, so the gate just isn't closing as tightly as it should. Sometimes supplementing with estrogen can help improve that tone and reduce leakage.
Interesting. What about other factors? You mentioned iatrogenic, environmental, demographics.
Sure. Iatrogenic means caused by treatment. So veterinary procedures like urinary catheterization or endoscopy, while necessary, can sometimes introduce bacteria or cause irritation if not done carefully.
Okay.
Plant intoxications, we mentioned sorghum and Johnson grass causing paralysis. Environmentally, diet plays a role, especially with stones. High calcium diets like lots of alfalfa can predispose.
Makes sense.
Demographics. Well, gender plays a role. Adult geldings, especially over 10 years old, seem more prone to incontinence and bladder stones, maybe due to their longer, narrower urethra making emptying harder or stone passage more difficult. Mares, on the other hand, with their shorter, wider urethra, are more susceptible to simple lower UTIs, like bacterial cystitis, possibly due to fecal contamination. Ectopic ureters are also more commonly diagnosed in females.
And age.
Age is a factor, too. Young foals, say under 30 days, are at higher risk for infections spreading through the bloodstream to the kidneys, septic nephritis, or sometimes fungal infections like Candida cystitis, especially if they've been sick or on antibiotics. Older horses generally might be more prone to urinary issues just due to potentially declining kidney function or other age-related problems.
Okay, now let's get back to that crucial connection you mentioned, chronic pain.
Yes, this is really important and probably under-recognized. Chronic musculoskeletal pain, especially if it's in the lumbosacral area, the lower back and croup, or even significant hind limb pain like from arthritis.
How does that link to urinary issues?
Well, think about how a horse postures to urinate. They have to stretch out, relax their hind end, often lift their tail. If that posture is painful,
They won't hold it for long or won't get fully relaxed.
exactly, they might cut urination short or not empty their bladder completely because it hurts to maintain the position. And what does incomplete emptying do?
It starts that whole cascade.
Right,
Urine pooling, sediment forming.
precisely. It sets off that sabulous sediment cascade we discussed, ultimately leading to chronic bladder overstretching, loss of muscle function, and potentially irreversible bladder paralysis.
So what does this all mean for someone caring for a horse? It seems like it means looking beyond just the urinary signs. A horse with incontinence, even if they don't seem obviously neurological, might actually have a painful back or hip that's the real root cause, preventing them from urinating properly.
That's absolutely right. It truly highlights the interconnectedness of their body systems. Sometimes the primary driver for a severe urinary problem is hidden somewhere else entirely, maybe looking like just a subtle lameness or back stiffness. You have to connect the dots. ###############################################################################################################################################################################################################################################################################################################################################################################################
is and knowing how tricky this can be, how do vets actually go about figuring out what's truly going on? The symptoms seem to vary so widely, from really subtle changes to quite severe illness.
They do. The clinical signs are definitely variable. Some general things to watch for include changes in urination frequency, maybe urinating much more often, which vets call polyuria,
Okay.
or maybe increased volume of urination, polyuria, difficulty or obvious pain during urination, that's dysuria or stranguria, and of course that involuntary leakage, incontinence, or dribbling. You might also notice changes in the urine itself, Maybe it looks red or has visible blood, hematuria, or just looks really dilute, poorly concentrated.
And you mentioned systemic signs earlier.
Yes, and the presence of systemic signs is a really critical indicator of severity, especially if we're worried about an upper UTI affecting the kidneys, like pyelonephritis.
What kind of signs are those?
We're talking about things like fever, general depression or lethargy, weight loss, maybe loss of appetite, drinking way more water than usual polydipsia, or even signs that look like colic. When these broader whole-body signs appear, it immediately elevates the urgency. It suggests a potentially more serious problem that's gone beyond just the bladder itself.
Okay. And for incontinence specifically, what are the hallmark signs again?
Beyond just the involuntary leakage itself, you'll often see that chronic scalding of the skin on the hind legs or under the tail, that distinct urine odor. And often, even if the horse tries to urinate voluntarily, the stream might be very weak or interrupted.
Got it. And you mentioned the neurological exam is key for differentiating those UMM versus LMN bladder issues.
Absolutely crucial. It helps us assess based on how the bladder feels rectally. Is it firm and turgid, suggesting UMN, or large and floppy, suggesting LMN? And we correlate that with any other neurological deficits we find, like gait abnormalities, tail tone, anal tone. That early and comprehensive neurological examination really is vital for pinpointing the potential site of the problem.
So it sounds like it's really important to differentiate between, say, a simple bladder infection, cystitis, and a more serious kidney infection, pyelonephritis. What's the key difference in how they present?
That's a critical distinction, yes. With straightforward cystitis, a bladder infection, you typically see those localized signs, frequent urination, maybe some straining or discomfort, but usually no fever, and the horse doesn't seem systemically ill.
Okay.
However, with pyelonephritis, meaning the infection has ascended up to the kidneys, you'll almost always see those systemic signs. Fever, weight loss, depression, maybe poor appetite, and potentially even pain if you palpate over their flanks where the kidneys are. The severity is just much higher.
Right. So how do vets put all this together? What's the diagnostic approach?
It becomes quite systematic. A detailed history is absolutely paramount. And what's fascinating here is how much the history can tell you, sometimes revealing clues from months or even years ago.
Like what kind of things?
We'll ask about the horse's age, gender, reproductive status if it's a mare. Their diet, are they on high calcium feeds? Environmental factors, any access to potentially toxic plants, any prior veterinary procedures like catheterization, any history of trauma, exposure to infectious diseases like EHV1, and crucially, any history of chronic pain, especially musculoskeletal pain in the lower back or hind limbs. And of course, we need a detailed description of the urination pattern the owner has observed.
So the owner's observations are really key.
Incredibly key. This is followed by a comprehensive physical and neurological exam. We'll try to watch the horse urinate if possible, perform rectal palpation to carefully assess the bladder size, its tone, wall thickness, and feel for any contents like stones or that gritty sediment, and then conduct that full neurological workup we discussed.
Okay, history and exam first. Then what?
Then laboratory tests become indispensable. Blood work, a CBC and biochemistry panel, helps assess overall health, inflammation, and importantly, kidney function markers like BUN and creatinine. And of course, a urinalysis.
What does urinalysis tell you?
A lot. We look at the urine's color, clarity, pH, specific gravity, which tells us about concentrating ability. Then microscopically, we look for red blood cells, white blood cells, pyuria, or pus cells, strongly indicate infection, bacteria, crystals, and other abnormal cells.
And culture.
Yes. Obtaining a sterile urine sample is vital for a urine culture and sensitivity test. This identifies the specific bacteria causing the infection, if there is one, and tells us which antibiotics are likely to be effective. This is especially important now with the increasing challenge of multi-drug resistant bacteria.
Got it. Any newer lab tests?
Yeah, there are emerging urine biomarkers. These are specific proteins or substances in the urine that act like early warning signals for kidney damage. Things like KIM1 and NGAL are proving to be quite sensitive indicators for acute kidney injury, sometimes showing up before changes in blood work.
Interesting. What if the picture is still unclear after history, exam, and labs?
That's when advanced imaging and endoscopy come in. Endoscopy, using a camera scope, allows direct visualization inside the urethra and bladder. We can look for stones, tumors, inflammation, strictures, or anatomical abnormalities like ectopic ureters.
See it direct?
Exactly. Ultrasonography is also very useful, often done transrectally for the bladder and reproductive tract, or transabdominally for the kidneys. It helps assess bladder wall thickness, identify sediment or stones, and evaluate kidney size, shape, and internal structure.
Any other imaging?
For more complex disorders, or sometimes in smaller horses or foals where rectal palpation isn't feasible, we might use X-rays, radiography, CT scans, or even MRI. These can give really detailed views, especially for things like stones or complex anatomical issues.
Okay, quite a workup.
It can be. Sometimes specialized tests like urodynamics, measuring bladder and urethral pressures during filling and voiding might be used, especially for prognostic information, but they're less common in general practice. Hashtag tag 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 5. Strategies for treatment and management.
So, after all that diagnostic work, it seems crystal clear that treatment has to be highly dependent on that identified root cause. You can't just treat the symptoms.
Absolutely not. That's the cornerstone.
And early intervention seems absolutely crucial because, as we've heard, chronic cases, especially with bladder paralysis, often have a poor prognosis for full recovery.
That's right. The longer it's been going on, the higher the chance of irreversible damage.
And I think we need to stress again, these cases often require a really substantial commitment from the owner, especially for the meticulous nursing care involved.
Huge commitment. It's definitely not a quick fix in many situations. Medically, if an infection is confirmed, antimicrobials, antibiotics are chosen based on those culture and sensitivity results.
Targeting the specific bacteria?
Exactly. Common culprits are things like E. coli, Proteus, Klebsiella, Pseudomonas, but we do face significant challenges with multi-drug-resistant organisms sometimes, like Stenotrophomonas multifilia, which necessitates very careful, judicious use of antibiotics based on sensitivity testing. We want to avoid creating more resistance.
Makes sense. What about drugs to help the bladder itself work better?
Yes, we have some options, depending on the problem. Bethentyl chloride is a parasympathomimetic. It helps stimulate the detrusor muscle to contract, which can aid bladder emptying.
So it helps squeeze the bladder.
Right, but its effectiveness is limited if the bladder is already completely atonic or paralyzed. And crucially, you cannot use it if there's any kind of obstruction downstream, like a stone blocking the exit.
Okay, important caveat. Others.
Phenoxybenzamine is an alpha blocker. It works by relaxing the smooth muscle of the urethra, reducing sphincter tone. This can make it easier for urine to flow out, especially in cases of UMN bladder dysfunction where urethral resistance is high. Sometimes it's combined with botanical.
So one squeezes the bladder, one relaxes the exit.
Kind of, yeah. Trying to coordinate emptying. Phenylpropanolamine, or PPA, is an alpha agonist sometimes tried to increase urethral tone in cases of sphincter incompetence, but its success in horses seems less consistent than in small animals.
Okay.
And as we mentioned, estrogens can sometimes help mares with that specific estrogen-responsive incontinence. And other drugs like DDAVP might be used for specific conditions like diabetes insipidus, if that's diagnosed.
Right. And for pain and inflammation. Standard stuff.
Pretty standard, yes. Non-steroidal anti-inflammatory drugs, NSAIDs, like flunixin, meglumin, maybe firocoxib for longer-term use, or phenylbutazone, are commonly used to manage pain and reduce inflammation associated with infection or stones, keeping the horse more comfortable.
What about diet? You mentioned that earlier with stones.
Yes, dietary modifications are critical, especially for preventing recurrence of urolithiasis or stones. The main thing is usually reducing high calcium feeds, particularly alfalfa hay or pellets. Ensuring constant access to fresh, clean water is also key to promote dilute urine. In some cases, vets might recommend urinary acidifiers like ammonium chloride or ammonium sulfate to help dissolve or prevent certain types of crystals, but that has to be carefully monitored. And things like fecal softeners might be needed if there's concurrent constipation, like with Cauda equina syndrome.
Makes sense. When does surgery become necessary?
Surgery is often the primary treatment for urolithiasis bladder stones or stones lodged elsewhere. Depending on the location and size, procedures might include a cystotomy, which is surgically opening the bladder to remove stones.
Okay.
Or maybe a urethrotomy to remove stones from the urethra. Sometimes minimally invasive techniques like laser lithotripsy, using a laser through an endoscope to break up stones, can be used.
What about those congenital problems?
Surgical correction is usually required for congenital anomalies like ectopic ureters, redirecting the ureter into the correct position in the bladder, or repairing a patent urachus in foals.
Any surgical options for incontinence itself?
For specific types like urethral sphincter mechanism incompetence, various surgical techniques have been described, mostly in small animals, but sometimes adapted for horses. These aim to increase urethral resistance, things like urethral lengthening procedures, injecting bulking agents around the urethra, or even placing artificial sphincters. But documentation and success rates in horses are generally less extensive, And of course, surgical repair is necessary for bladder trauma, like a rupture.
Right. So beyond specific medical or surgical fixes, that supportive care and nursing you mentioned sounds absolutely vital.
It's often the backbone of management, especially for chronic cases or horses recovering from procedures. It's critical for the horse's comfort and preventing secondary complications. And again, demands that meticulous ongoing owner commitment.
What does that involve typically?
A major component is often bladder emptying. If the horse can't empty on its own, this might mean regular, sterile catheterization several times a day, or sometimes manual expression by the vet if the bladder is flaccid. Bladder lavage, or flushing, might be done periodically, especially to help remove that sabulous sediment.
Okay.
Managing urine scalding is huge. This requires meticulous daily hygiene, gentle cleaning of the affected skin on the hind limbs and perineum, and applying protective barriers like petroleum jelly, zinc oxide cream, or glycerin-based products.
Keeping the skin protected.
Absolutely. Fluid therapy might be needed initially, often intravenous isotonic crystalloids, to correct dehydration or support kidney function. Encouraging water intake is always important. And pain management needs to be tailored to the horse using NSAIDs, sometimes opioids if needed, maybe local anesthetics, alongside addressing the underlying cause. #6, prognosis and potential complications.
Okay, putting it all together, it's clear that the prognosis, the likely outcome for these conditions, varies dramatically. It really depends heavily on the underlying cause, how long it's been going on, and whether there's already irreversible damage.
That sums it up perfectly. Generally speaking, the prognosis tends to be favorable for conditions that are clearly identifiable and correctable. Think of an ectopic ureter that can be surgically fixed, or a bladder stone that can be completely removed without long-term bladder damage.
Okay.
Also, if the cause is an acute neurological disease, like maybe EHV1, and bladder function starts to return relatively quickly, say within 10 to 14 days, the outlook for recovery can be quite good.
But what about the less favorable scenarios?
The prognosis becomes much more guarded to poor for long-standing incontinence, especially when it involves significant bladder paralysis, meaning a large, atonic, non-contractile bladder, and particularly if there's a large amount of that sabulous urolithiasis present.
Why is that?
It often indicates that the bladder muscle dysfunction, the detrusor failure, has been present for months or even years, leading to irreversible stretching and damage to the muscle and nerves within the bladder wall. At that point, even if you address the original cause, the bladder itself may never regain normal function.
So time is really of the essence.
Absolutely. Incontinence in mares, particularly if it's idiopathic or long-standing, often carries a guarded to poor prognosis. Although, again, if a specific structural abnormality like an ectopic ureter is found and corrected surgically, that can be successful. For something like cauda equina syndrome, the prognosis really depends on the specific cause of the nerve root inflammation.
Right. And beyond the primary issue itself, several common complications can arise or make things worse, creating even more challenges for the horse and the owner.
Oh, definitely. Urine scalding is probably the most common and can be incredibly frustrating to manage. It requires that constant, meticulous daily care to prevent severe skin damage and secondary infections.
Very labor-intensive.
Very. Then there are ascending UTIs. These are a frequent problem because that stagnant urine from incomplete emptying creates a perfect environment for bacteria to multiply and travel upwards, potentially reaching the kidneys.
Makes sense.
Sagulous urolithiasis, that gritty sediment we keep mentioning, not only results from poor emptying, but also exacerbates the problem by further irritating the bladder lining and potentially contributing to obstruction and overdistension, pushing the bladder towards complete bladder paralysis, which, as we said, can unfortunately be irreversible.
Vicious cycle.
It really is. And if a severe kidney infection, pyelonephritis, goes untreated, or if obstructive urolithiasis blocks urine flow completely, it can lead to progressive damage and ultimately kidney failure, which carries a very poor prognosis.
Other risks.
Secondary fungal infections can sometimes develop, especially in the bladder, sometimes following prolonged courses of antibiotics that disrupt the normal microbial balance. And probably the most catastrophic, though thankfully less common, complication is bladder rupture, usually resulting from a complete untreated obstruction. That's typically fatal if not addressed immediately surgically.
It's definitely a complex and challenging area, but it's also an evolving field. So let's take a quick look at how recent research is advancing our understanding and treatment of equine urinary tract issues. What's sort of on the horizon? What's exciting?
Yeah, there are definitely advancements happening. In diagnostics, we're seeing continuous improvements in imaging technologies. High-resolution ultrasonography gives us much clearer views of bladder walls, sediment, kidney structure, and advanced techniques like CT scans and MRI, while maybe less accessible, offer incredible cross-sectional detail, especially for soft tissues.
Seeing things we couldn't before.
Exactly. There's also more work being done on those urine biomarkers we talked about, KIM1, NGAL, and potentially others, as sensitive early indicators of acute kidney injury, which could help us intervene sooner.
What about identifying infections faster?
That's another area. Advanced molecular diagnostics, like LMP technology, loop-mediated isothermal amplification, are showing promise for really rapid bacterial identification directly from urine samples, potentially giving vets results in, say, under 20 minutes, which would allow for much quicker, more targeted antibiotic choices.
Wow, that would be a game changer.
It could be. And interestingly, research, mostly in human and canine medicine so far, has identified intracellular bacterial communities, or IBCs. This suggests bacteria can actually hide inside the bladder lining cells.
Like invaders hiding inside the castle walls.
Kind of. Potentially evading standard urine tests and antibiotics that primarily work in the urine itself. This hasn't been extensively studied in horses yet, but it highlights a potential complexity we might also face in recurrent or resistant equine UTIs.
Fascinating. What about on the treatment side? Any new approaches?
Well, regenerative medicine is an area of interest, though still largely experimental for urinary issues. Things like stem cell therapy or using platelet-rich plasma, PRP, are being explored for their potential to promote kidney regeneration or tissue repair after injury.
Still early days, though.
Pretty early for routine use, yes. There's also ongoing research, again drawing from human medicine, into more targeted antimicrobial approaches. Things like manicides that might prevent certain bacteria like E. coli from sticking to the bladder wall.
Stopping them before they attach.
Right, or molecules targeting bacterial pili, the little legs they use to attach. Even research into vaccinations against common uropathogenic bacteria. These are mostly future directions for veterinary medicine, but they show where things might head. There's also work on optimizing antibiotic durations, exploring things like iontophoresis to deliver drugs directly into the bladder wall, or developing antibiofilm therapies.
And surgery.
Minimally invasive surgical techniques are definitely becoming more common where appropriate. Using laparoscopy for abdominal procedures or ureteroscopy for viewing inside the ureters and potentially treating stones there. These usually mean smaller incisions and faster recovery times. And while still complex, there are ongoing advancements in things like artificial urethral sphincters, which might one day offer better options for severe refractory incontinence in horses. Hashtag tag outro.
Wow. This deep dive has really highlighted how a seemingly simple problem, like a horse just dripping urine, can have such deep, complex, cascading origins.
It's really straightforward.
Right. The complexity of equine UTIs and incontinence truly shows how these diverse causes can funnel down into a common, often self-perpetuating cycle of bladder dysfunction. And so often, the primary issue is hidden, obscured by those chronic symptoms that have been going on for a while. It just underscores the profound importance of getting that diagnosis early, getting it accurately, and taking a truly holistic approach looking at the whole horse.
Absolutely. You can't just focus on the bladder in isolation.
It really makes you think differently about managing equine health, doesn't it? And how interconnected all these body systems truly are.
It absolutely does. And considering how things we've discussed, like a horse's environment, its diet, or maybe even an old overlooked musculoskeletal injury, like that sore back, can silently contribute over time to severe chronic urinary issues.
Well, it raises an important question, I think. What other subtle signals might our animals be giving us about their health right now? Signals that we're currently overlooking, just waiting for us, to connect the dots.
That is a powerful thought to end on. Really makes you observe more closely. We hope this deep dive has given all of you listening a fresh perspective and a really robust understanding of this complicated topic. Thank you so much for joining us.
Thanks for tuning in.
And we definitely invite you to continue your own deep dives into all the fascinating topics out there in equine health.